Hello and welcome to Sensei Podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei Podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello, everyone, and welcome to Sensei Podcast. It is my great pleasure to introduce our guest today, who is Chad Kugler. Chad is not our typical guest because actually he's an engineer. He's not a physician, but I think he knows more about CTOs than many of the physicians, especially at the early stages. And actually, I've learned a lot from him at the early stages of learning CTO PCI when he was running Bridgepoint Medical. So Chad Kugler, he's an engineer by training. He's been with multiple companies. As he will tell us, he founded Bridgepoint, which gave rise to the Crosspost and the Stingray, and now he's the president and CEO of Seigla Medical. So, Chad, thanks again for being with us today.
Well, thanks for having me. It's a pleasure. It's great. And nice introduction. Very nice. So thanks, Manos. We've known each other for a long time. I'm actually excited about doing a podcast with you. This is kind of a unique forum and a unique opportunity. So thanks.
No, thank you. Thank you, Chad. And I will recall my old days and just getting your thoughts on this. So I was back in the Dallas VA. That's, I think, 2009, 2010 or so. And I remember we were learning to do CTOs. And there is this company who has this device and they want to be in every case in there. And they come in and initially like, why in the world do they want to be in every case? What's the big deal? But then you guys came in, yourself and part of your team. And it was amazing. I mean, you guys had seen many more CTOs than I had ever seen. And you gave amazing feedback and helped us a lot, myself and the rest of the team, to learn and do CTO. So how is it possible for an engineer like yourself, who doesn't do procedures, to understand the procedures so well to be able to guide physicians and create new devices?
That's a good question. It's actually been quite an interesting journey to get to the point where your observational experience is at that level. So creating a new device in CTO, early days, we didn't really know how to use it either, right? So the whole part about how successful is a device, how well are people using it, taking experiences from one lab to the next, and understand exactly the way to get the best efficacy out of any kind of procedure. You really have to be there, right? So at that time, I and the Bridgepoint team were doing a lot of work in different labs, and it wasn't just different labs in the U.S., it was different labs around the world. So I found myself in early days in South America and Chile doing first in human experiences down there, in Europe in clinical trials, in Germany and other places. I was actually in Japan at Toyohashi with the Japanese masters. So at some point, I actually, observationally had seen so much that you could help physicians in their early learning phase just identify things on an angiogram, right? We're not doctors, we're none of that. We're not treating patients, but that observational experience, because, angiography is, so visual and so observational, we were able to really add some value in those days and learn from each physician as they were doing things. I mean, our early days in Dallas, right? We didn't quite know what we were doing, right? We're going along and figuring it out and doing both coronary and peripheral cases with you guys, you and Subash. And those were really our formative years. So all those things helped the company, helped CTO PCI, helped us bring those experiences from your lab into other labs into your lab. We became sort of part of the team, which was a lot of fun.
So maybe we can take it a step earlier, as you said. You started the company and created as far as I know, the only successful CTO device in the last 15, 20 years. How did you come up with the idea? And how did this, evolve into what it is today?
So we started an incubator back, a couple business partners and I, in late 2005, 2006. And in that, what you do is you look for different areas of medicine. I started my career at SciMed Life Systems as an engineering intern. So I'd been in cardiology, been in startups at that point in my career most of the time. And we ended up in the CTO, looking at the CTO space again. And it became empirical a little bit, right? So, what is a CTO? What does it feel like? I'm an engineer, curious. We ended up getting cadaver tissues from bypass patients, understanding what intima, media, adventitia is, doing some experiments, and then starting to synthesize away. And I realized that even the published literature, the things that are out there, some anecdotes that said that if you put a drug-eluting stent in place across the CTO, it was good, the efficacy was good. It stayed open, stayed patent. And there were actually even some anecdotes where some physicians had recognizedly placed stents in subminimal spaces, case studies, that kind of thing. Nothing, no randomized trials, but enough there to say, hey, if we could get a stent in place across these things, that you might have a treatment. And so it started this whole process of us, looking at what the tissues were and what we could do, what happened when you put a device in, a wire in, all these things. And, it took, it probably took 150 cadaver hearts, overall in our entire experience between our early days and plumbing these things up and putting them in a cath lab environment and having physicians do it. So we just iterated through and then recognized some mechanisms, what blunt dissection was, that was sort of our cross boss. And then to re-enter exactly what the mechanism was there, recognizing that what happened to devices in subminimal spaces. So that was really sort of the genesis is more of an empirical experience. We weren't physicians. In fact, in some ways, I think because we weren't, that was beneficial because we didn't know we weren't supposed to go in the subminimal space, right? That was a bad thing. And I think that's probably one of the things we brought is that knowledge, the empirical information, the experience for early physicians that did some of these cadaver hearts with us kind of was the guide to bring it to the forefront and get it embraced and get people comfortable. So yeah, the genesis of the Stingray Crossboss, the Bridgepoint devices was more of an empirical try, succeed, try again, fail, and just kind of go through it until we finally came up with a set of tools that did the job.
And my understanding is it's not always easy to find hearts that have CTOs, right? So that part too might have been a little challenging. Is that right?
Yeah, I mean, I think we could donate tissues for research, right? Such a gift that you can get these things because without them, you couldn't do the work we did. From bypass patients, by definition, they've got a lot of atheroma, or renal failure patients was the other selection that we could get, and then we knew that we had a lot of disease. So that was really the things we had to do. But there are sources of tissues. It isn't easy. But was a crucial resource for us in those days to figure it out.
And then it's interesting, the parallel. I think 2005 is when Antonio Colombo published his STAR technique, right? The first real paper saying that you can go subintimal or extra plaque, as we say now, and dissect and get back in. And obviously, that's not exactly what you are doing. You are much more controlled and limited in terms of the length. But it's interesting, that's when you started your journey. So maybe sometimes coincidences can have good outcomes and good synergies there.
No, that's exactly it. And that was some of the foundational information is Colombo was doing that work in different publications that were out there. And there's also the whole subintimal angioplasty piece in the peripheral which was being done, for limb salvage and those procedures. So there was some foundation here. So, it isn't new. It was just a mechanism that, as you said, created kind of better control and a way of doing it in a procedural fashion. At the time, people didn't really think STAR was a good idea. Too much stenting, subintimal stenting, all of this, right? It was pretty controversial, but it did, bring that technique to the fold and did show that there was some efficacy in certain patients and that it did work. The whole question was outflow, number of vessels, all those things, and that's why people didn't really conceptually like STAR, and why this, I think, did, provide some additional solutions and different opportunities.
Yeah, no, absolutely. And I think, it took a while, as you said, to get people to accept it, understand it a little better. But the whole point of this podcast is actually about learning. So what amazes me, as you said, is that you are able to get a very good understanding and be able to guide people to do these procedures, although you haven't done it yourself. And again, you watched many labs and you've been there. But how did you actually learn to understand what was going on? I know you're observing things, but what people say is if you don't do it, you don't learn it, right? So you're able to learn it without necessarily doing the actual steps yourself. So how does that work? Because that's very powerful, right? The fellows complain that, hey, they don't touch the catheter, they're not going to learn, and we embrace that. But from what you're telling me, it's possible to learn a lot by watching and being able to understand what is going on.
Yeah, I think in that cadaver heart forum, being that we were able to, do a mock cath lab, scenario, I would absolutely agree with you that, how do you understand what a doctor's doing if you don't get to do it yourself? How do you make tools for a physician if you don't get to do it yourself? As engineers, we have to somehow figure out how to synthesize that or how to mimic the cath lab environment as much as possible and try it ourselves. So the cadaver hearts, we were actually doing cases, right, with these procedures. And so, I could do it, right? I was the first one to do a stingray or entry in the world, but it was done in a cadaver heart, right? And then we worked with physicians in the early days. It was Pat Whitlow from the Cleveland Clinic. Pat's no longer with us, but he was really foundational for us to learn. He came and did these procedures with us. Bill Lombardi did procedures in those early days on cadaver tissues. And so that really did help us learn because we could touch in that environment. And then, the angiogram, you can learn observationally by watching, if you're in the true lumen, how wires act. That part of it is something that you don't necessarily have to do to recognize. Now, that being said, put me on a live patient, I couldn't do it, right? I don't know all the things of doing cases, but the things that were important to this procedure, observationally, I kind of knew what the physicians were feeling. I could watch on an angiogram and recognize the same cues you're seeing during the case. So that gets us, 75% there, right? And in that, I think that's helpful to physicians, especially in the early days. You can bring again that those things you learned along the way from lab to lab, and that's beneficial. So so I think there's pieces of it that we got, right? We did get some of the tactile part of it. We did get some of the hands-on part of it, but not the same thing as doing a live case.
And then when it comes to teaching people, you've seen many physicians, right? You work with so many people all over the US, the world, actually. When you work with them, did you have a sense in the beginning that this is going to go well or not after, you've done it for so long?
Yes and no, right? All of our experiences weren't positive in those early days. And, some of it was case selection, using the right tool at the right time. I mean, that's how this practice works, right? So, the antegrade dissection reentry is not the right procedure for all cases. And in the early days, we didn't know that as well as I think it's known today. The experience of the operator, came into play in those early days where it seemed like some operators had been doing more of these cases or were more open to trying these things. Others were less open. Again, it's because we didn't know, and you're doing something new, and it's difficult to do something new. But in the early times, maybe we were 50% successful just because we didn't quite understand how to use the tools. But as time went on, applying the right technology to the right case at the right time, using the right technique, started to accelerate, our success rates. And it got to a point where I could go in, and if I was quote unquote proctoring cases, right, I would expect to be successful, 80% of the time, which is pretty good in the cases that we're doing. Because if a physician was willing to collaborate, right, and listen, then we could get success. But then again, there were also times which, wrong time, wrong case, still, it was difficult. But, it was, again, experiential, and we just needed to do more cases and know exactly how to use those tools. And that, was lab by lab, doctor by doctor. So many people made different contributions to the success in those days. But more cases, precipitated greater levels of success. And again, our time at the Dallas VA, right, when you were there, those were those formative years. We learned this together models. Do we use it now? Was it successful? Why was it not successful, or why was it successful? And there were some wonderful times there, right? Cases that you knew that otherwise wouldn't be done or wouldn't have been successful without the technology. And that was so much fun. So much fun to help in that way.
No, absolutely. And again, I think, as you said, part of it is the interaction and being open to new ideas and new technologies. And not everyone is necessarily doing that. And I think sometimes the longer you are in practice, maybe it's harder to embrace new ways of doing things. So I wonder if you've seen that, if some of the more senior physicians that were more established in their ways had a harder time to adopt the new way of doing things.
Yeah, I think that's true, and there's all kinds of barriers too, right? So many industry people are around labs today, right? And so many salespeople, and there's issues there sometimes, and sometimes not issues there. And so for someone that's not a physician to be standing in a lab and to have a doctor collaborating or listening to somebody is really not, as normal. It's not. So I had to find strategies to convince people that we knew what we were doing, and talk to physicians in a way that, hey, I'm not a doctor, I'm not treating your patient, I'm just seeing something that, can I see a lateral view? Can I? And as you talk through them, or can I see the case in advance? They realize you're bringing not just, hey, I want to sell my thing. I'm actually trying to help precipitate success in your cases, which is really it, right? An open artery is all that we were ever interested in doing. And if it was to be wired antegrade, do it, right? You don't need the technology, don't use it. It was that whole piece of it that I think we refined exactly what we were doing and how to do it and how to interact. But to your question, yeah, I mean, sometimes people think that they have it all figured out and don't, right? Some are very interactive and some aren't very interactive, but over time I found that you can win people over just through bringing value, being able to talk about it. I always tell the story, one of the best ways to teach or train is, I'd say, okay, if there's somebody else in the room, another company person, I would say, hey, the doctor's doing this. The next step they would do is take a lateral view to make sure that their wire is tracking and dancing with the artery. Because I was watching and knowing that they just got off in a branch, but the doctor wasn't recognizing it, right? So as they're learning, and you would see something, what you do is not tell, hey, doc, you're off track. You'd say, hey, right now they're going to take a lateral view because that's the right thing to do. And next thing you know, the person takes a lateral view, they look, and they say the wire's off track. The person looks over their shoulder and goes, okay, that guy knows what he's talking about, right? So that was some of the stuff we had to do to really, make sure that we respected the relationship with the physician, the fact that people are highly trained, that it's their job to treat patients, and you're only there as an observer. But there were ways to be smart about it, right? And gain people's respect and confidence that if you're asking something, that maybe I'm seeing something that they're not. So yeah, that's all part of it. It's being a good citizen and trying to help.
So essentially allowing people to save face, right? You don't say directly, hey, this is wrong. You just describe to someone else and directly. That's brilliant. I think we can all use a lot of that.
Right. So there were times in which where someone would say, well, why are you listening to him? He's not a doctor, right? Well, and then the whole discussion would come up, right? So it's just the observational experience, right? And that's one thing at Bridgepoint we trained our people to do. If it was the engineers, we had a direct sales force for a time. And then when Boston bought Bridgepoint, that was the same thing that we told them and trained them to do. There's still Bridgepoint employees working for Boston Scientific doing this and proctoring and helping that way. And it is the fact that, hey, we're all here to treat the patient. There will be devices used, and use the right tools at the right time. Make sure that you're focused on the outcomes. Because that's what we're here to do, right? So that was just such good fun, right? There were times in which when you got done, people would say, "You can come back anytime," right? You can come back anytime. Bridgepoint, we did create that environment where we were welcome in labs. Oftentimes called to say, "I've got a CTO day, could you come?" Because we were relevant and helping, and I felt like we were doing it the right way. And I learned that from you, from the early days of the physicians, right? I learned that from Bill and Craig and Aaron and Mike Wyman, being in their labs and them being so gracious to me, made us recognize exactly what our roles were. That it is trying to disseminate CTO PCI, trying to get more patients treated. And in that, all boats would float along the way. And that was really the case.
Yeah, no, again, it was a phenomenal time. It's a lot of learning, but at the same time, that's when things became standardized. I think you were the one who organized the Bellingham meeting where the hybrid algorithm came out. So a lot of the seminal things happened during this period of time that you were helping with education and doing all these courses, while at the same time learning. How did you learn about the stick and swap? I know that's been something that now is obviously no one thinks about it, but now we take it for granted. But how did it actually evolve?
I believe so. Yeah, we were in the early days of all this, right? And doing a U.S. trial, very few centers actually had access to Stingray Crossboss. It was our fast CTO sites in those days, of which you were one of them. And so people were doing different things at the time, and I was interacting with them all, right? Either at their labs or someone would have a case and they'd call. And so we had the classic stick and drive, get the Stingray. We're using Stingray wire back then. Hadn't recognized that, some of these other wires were preferred over the one that we were providing. Some had mastered the stick and drive, even with the Stingray wire. Craig Thompson, I think, was the first to start the stick and swap, right? So and poke both sides and then, try to chase it with a Palmer jacket wire. His creativity table side in those days brought that technique to the fold. And at Bellingham, that's when those things were sort of shared, right? Different people's techniques. You had, 15 physicians, right? That were mostly U.S., but some Canadian, some European physicians bringing the best of antegrade and retrograde CTO PCI into one room, and then the debate of and how you do that. And so, each of those techniques kind of got brought in. And I think that's when really people saw the fact that there were things that they knew and there were things that they didn't know. There were things that they were really good at. There were things that they had to get better at. The stick and swap came from Craig, but different techniques came from different people along the way, other techniques as well.
Perfect. And then when Boston acquired Bridgepoint, then that literally launched, I would say, the most intense training period in the history of CTO PCI in the US, at least, with massive proctoring and training many, many labs in many places. So what did you learn from this experience? How many of the people who actually expressed interest eventually ended up adopting it and becoming solid CTO operators?
Yeah, I think so. The fun thing about Bridgepoint, it was, quote unquote, it was new therapy, but it was new technology, right? It was a new way of doing things. People saw the knowledge to use it, and there was a training. We sponsored a lot of training courses, but it was also quite a burden to do it, financially for a startup company. So, that was hard. So, bringing the device to a larger corporation was the right path forward because, deeper pockets, more products being sold, all these kinds of things. There's a business that, is behind all of these things because there has to be. So it was the right thing to have Boston take this on, right? And they did a good job, to your point, right? They accelerated all of this. There are a lot more labs, right, doing this and doing it with excellence. As a result, there are relevant, physicians, new faces, new operators, which is really fun to see. And there's also a cast of other, industry people that know the cases and can proctor and move around and help teach and train. But I think there's still a long way to go, right? Not everyone's doing it with excellence. It hasn't arrived yet, I don't think. In terms of its dissemination, through the U.S. and throughout the world, it's a lot better than it was 10 years ago, right? We've come so far, but I think there's still a long way to go.
Perfect. So Chad, you never stop. So you did all this work, and now you're in a different startup with a thin guide extension, which makes perfect sense with Seigla Medical, the Liku ID. So how did this come through, and how you pivot from one area to another area?
Yeah, so I need a platform from which to do these things, right? That I enjoy, technology and trying to add value to medicine. It's sort of my life's work and something I need to continue. Seigla is so most companies are venture capital funded, right? And it's a great source of revenue, but it's also a great source of heartache for people like me, right? Professional money and investors that care about returns and just about returns, right? Not about people or patients or none of that. And that's maybe a little harsh on that world, but it is a little bit that way. And so Seigla Medical is it's a private company. It is not venture funded. It's funded with business partners from Europe that are distributors of medical devices. And we're building a new company, right? It gives me the forum in which to do the things I want to do and bring new devices. We're starting with a guide extension. It's a good business to be in. It's differentiated. That's not what this podcast is about. It's more about what we're doing and why we're doing it. Is it just allows me to continue to do the work that I like to do with unencumbered by or less encumbered by the financial folks and the constraints that come along with a typical startup company. So it's about freedom to do what you like to do, to continue to innovate, to try to add additional value, and and the things that we like to do in terms of engineering and devices and technology. So that's what Seigla is.
But I would argue this is also very relevant to the podcast because it's learning. So you learned a lot about CTO. Now you're learning
Great.
about guide extension. I mean, still PCI, so the area is similar, but I guess you have to learn different skills or different techniques and different materials, I presume, to be able to develop this. So that means that you're keep on active and wanting to learn and expand to new areas. So how do you do that?
Yeah, that's a good question. So I've always, the whole ideation part of it, the engineering part of it, that's all been very kind of natural to me. So that is sort of who I am, sort of an inventive person, right? Entrepreneurial. That's, I think, maybe it's a gift, or I'm born that way, and that's kind of how I have to live life, for better or for worse, right? So there's challenges in that, but I like unsolved problems. I like to try to do it. So it is to learn new materials, new ways. With this, we had to kind of come up with a new way of manufacturing devices and use materials differently to build the guide extension that we have. And along the way, right, it is a smaller company than Bridgepoint was, fewer people. I'm doing more, right? So you end up learning, any place from regulatory activities at a deeper level, manufacturing at a deeper level. So there's, in each environment that you find yourself in, there's new lessons to be learned, good lessons, bad lessons, easier things, fun things that are not so fun. We all have that in our lives. And it is because I have to do it. I don't really have a choice. That's who I am.
So it's the internal drive. I guess you were born with that.
I think so. I guess that's why. I mean, I think people's skill sets are set for different things, right? And I think mine tends to be, smaller company, higher risk. That's what I seem to gets me up in the morning, right? So you fit in the world where you fit in and play the role you do. So that's what I'm doing.
So, Chad, what are you most proud of? You've done so many things, obviously, already, but what are you most proud of so far, professionally or personally?
Well, I guess maybe that's two questions, professionally and personally, right? Because you have to have both a professional life and a personal life. I'm quite proud of my family, right? I have 3 kids and a wonderful wife and a great life, and I'm very proud of that. They have supported me through all this because it's not easy. If I'm in traveling around the world, it means that I'm not here. So they've enabled all this for me, which is fantastic. And professionally, I think it's the time I get a call from someone, I still do, saying, "Hey, I just did a case, and without this, I wouldn't have been successful." Right? So it's the clinical outcomes and adding something to medicine. I've done this in coronaries. There's a few other things I've done in my career that have had an impact in medicine. And that's really it, right? I feel good about having done something and maybe having had an impact that's lasting on people's lives. It's a small role, I guess, in all this, but it's one that's meaningful to me. And why I continue to want to do this is because it is rewarding that way.
Yeah, well, I would argue it's actually a fairly significant role. But what is your favorite book and your favorite movie?
Oh boy, yeah, good question. So I'm a child of the '80s, right? So the whole Star Wars saga to me still is something that no matter what, I could see another movie, but a kid watching that in the theater, back in the '80s was just, amazing, right? All of the cinematography and things you hadn't seen before, that was pretty cool. And I still, sort of like that. People my age probably all would say the same, right? Star Wars, it was cool. And book, Endurance. It's the story of Ernest Shackleton's, voyage. Do you know the book Endurance?
I haven't read it. I've heard about it.
Right. Yeah. So it's a story of perseverance and a captain being stuck in the pack ice and, boat crushed and everyone lived. Right. So surviving, the Antarctic winter and the stories behind that and the leadership there to me was amazing. So that's my favorite book.
Perfect. And then what excites you most right now?
What excites me most right now? I'm still inventive, right? I think that's probably it. The thing that, I'm a hobbyist. I do a lot of different things, right? So to me, it's still about technology and learning different things and trying to keep yourself on the cutting edge and push yourself. I think that's really kind of what I do and who I am, building projects, whatever else. I have, kind of extensive, workshop at home and that kind of stuff. I enjoy that part of my life. But family and all sorts of things. It's a lot of things that I enjoy to do.
So, Chad, again, thank you so much for taking the time. If you had to summarize from your learnings, some piece of advice for both physicians who are learning to do CT or complex PCI, but also for engineers, what are the things that you would advise them to do?
Boy, I think it's really the open mind part of it, right? Learn from the people around you. Listen to the people around you. None of us know everything. No one's omnipotent, right? So you have to make sure that you don't get stuck in a thought process and a thought pattern that you always think that you're right. Right. And as we get older and more accomplished, we tend to get that way. So, how do you keep yourself learning and listening? I think that's it. That's important.
Perfect. Well, Chad, thanks again so much. It's been wonderful talking to you. Thanks for everything you've done for the field, and thanks for the early days teaching us how to do the procedures and getting the device available, which again still remains one of the mainstays for complex lesions. Thank you so much, and excited to keep on working with you.
No, thanks for including me in all this. Great discussions, great questions. Thanks for being kind, and look forward to working with you as well. It's been a real pleasure.
Thank you for listening to the Sensei podcast.